now, and then you'll get a little box pop up on your screen. And if you're happy to stay in the meeting while it's recorded, then if you could just press continue, that would be great. Secondly, you should have received in the email with the joining instructions some information about the fact we're going to use Menti tonight. For those of you who've not used Menti before, it's kind of like an interactive feedback tool. So it just makes the lecture a little bit more interactive. It's very easy to use. And as the lecture gets going, we'll share a code with you, and that code will link up to Paul's slides that he's put together. So it means you'll be able to kind of respond in real time, and we'll get to know a bit more about who's joining the lecture today. But if there are any questions on Menti that if you're not able to access Menti at all, that's not a problem. You can just respond in the chat. We will be having a Q&A at the end of the session this evening. We should have about 15 minutes roughly for Q&A. If you could make sure you pop the questions that you've got into the Q&A box at the bottom of the Zoom screen. It's at the bottom if you're joining on a desktop. That would be great. If you could not put them in the chat, because they will get lost. So if you put them in the Q&A, they're nice and organised, and we can answer them either at the end. If they're to do with the lecture and its content, then Paul can answer as many as we can at the end. But if they're anything to do with the admissions or getting into medicine, anything like that, myself and my colleague Claire, who are in the webinar, will answer them as we go along. But yeah, like I said, please put them in the Q&A. And if you've got any queries as we're going along about terminology, or there's something that you don't understand that's being discussed in the talk, you can pop that in the chat and we'll get back to that, and I can stop Paul midway through and just get a bit of clarity. Please don't feel like you need to sit there a bit lost. So if you've got any worries on that front, then please do just pop that one in the chat for us. Wonderful. I think that is everything with regards to housekeeping tonight. So I will introduce our speaker for this evening, who's given up his time tonight. So Paul is a doctor who is training to specialise in anaesthetics. He's now based in Manchester, where he lives with his partner, their 2-year-old daughter, and their very excitable puppy, although he was previously a student at BSMS, where he did lots of work with the Brighton Widening Participation Programme. Wonderful. So I will hand over to Paul. Thank you so much for giving up your time tonight.
No problem. Thanks very much, Alice. So yeah, hi everybody. Nice to see you all, or not see you all. So unfortunately, I can't actually see any of you at the moment. So it's a bit like talking into the ether, but hopefully you can all see and hear me okay. So what I'm going to be talking to you about today is an introduction to anaesthetics. So hopefully you can all see that slide that I've just popped up there. Basically, what I'd like to talk to you about today is what anaesthetics is, what we as anaesthetists do, and what our role is in the hospital. Very briefly about myself, I am an anaesthetic registrar. So what that means is I'm a doctor in training to become a consultant anaesthetist. I graduated from BSMS back in 2015, and I've worked a little bit around the country before settling here in Manchester to do my anaesthetics training. I'm now about halfway through my training, or just a little bit past the halfway mark to being a consultant. So I'm still very much learning. I'm not there at the end yet. I've got roughly an hour with you guys tonight. So I was going to spend about 45 minutes at most talking to you. And then there'll be plenty of time at the end to answer any questions at all that you've got about anything that you've thought of beforehand, or anything that we touch on tonight that you think you'd like to know a little bit more about. But it would be really, really useful, if it's okay with you guys, to find out a little bit more about who I'm talking to, because I can then use that to adapt this talk a little bit and make it a bit more relevant for you guys, and hopefully a bit more useful for you. So if you go to that website, menti.com, hopefully you can now see that up on my screen as well. So if you go onto menti.com, it'll ask you for a code. That code is there at the top of the screen, 45203790. So if you pop that in, hopefully it should come up with this question. Oh, fantastic. And really, I just want to know whereabouts you guys are at the moment, whether you're all UK based, whether we've got anybody from overseas, because things are a little bit different in how anaesthetics are done in different countries. Fantastic. So Brighton, obviously heavily featuring with BSMS, London, as we'd expect, and Manchester. Brilliant. So as I said, I'm from Manchester, so great to have some local people as well. Oh, great, loads of people. And can I see anybody from overseas? So lots of UK places there. Oh, Galway, fantastic. Brilliant, excellent. So really are scattered from all over, aren't we? That's fantastic. Great. On Singapore. Oh, wow. Okay. Well, I'm going to have some questions for you about how things are in Singapore rather than and South Africa. Wow. Okay. Gosh, that's exciting. Okay. So next thing that'd be really helpful that I could find out about you guys is roughly how old you are. So which bracket of these do you fall into? I'm expecting a lot of 16 to 18, perhaps interested in going to medical school or interested in medical sciences in general. Perhaps a few people from different age groups. Okay, 11 to 15, great. So in your secondary school age, maybe starting to think about what you want to do for a career. And then a few from the older groups as well. Fantastic. So 178 of you logged into Menti, so that's most of you. Brilliant. Okay, so that's what I was expecting and hoping for. So roughly that split across kind of getting towards thinking about what you're going to do for medicine if you're interested in that, or medical sciences. Great. And lastly, this is what I'm really going to use just to help adapt my talk. What words come to mind when you hear anesthesia as a word? Okay, so just pop one or two words down together, little things. Fantastic. Brilliant. So anesthesia, anaesthetics, anaesthetist. You can pop in a couple of answers. I think I've set it up to let you do 2 or 3 answers for it. Good, okay. So yeah, so the big 2 words I was expecting to see are right there in the middle. So surgery, absolutely. We'll talk a lot about surgery and what our role as anaesthetists is with surgery. And sleep is definitely the other one that I was expecting to see. Yeah, hopefully that's because you think we put patients to sleep rather than we put you to sleep when I'm talking about anaesthetics. But yeah, there's some other great words, really important words for anaesthetics. So pain, pain relief, painless. A few other ones like needle and needles, they come up a lot with anaesthetists, and that's brilliant. And then lots of other interesting stuff there. Attention to detail, mathematical, complex, precise. Okay, that's brilliant. Right, knocked out. Okay, so that's going to be really useful for me because that will give me a little bit of an idea about how to tailor this talk for you, and about, in particular, a few of those kind of misconceptions that you can see even just from those few words about what springs to mind with anaesthetics. So that's great. Thank you so much for doing that. I'll mention as well something that Alice said. If you've got any questions at all, the way to ask me those really is in the Q&A thing at the bottom. So if you ask me in the Q&A rather than in the chat, that way, if you see other questions you think, oh yeah, I want to know the answer to that, you can upvote them, and then they're much more obvious to me at the end which things you really want to find out about. So do use the Q&A if you think of anything at any time that you want to know. It's hard for me to see them while I'm talking. I'm sure Alice will interrupt if there's anything really pressing. But otherwise I'll see them all at the end, if that's okay. So lots of what you guys mentioned when I asked you what you thought of when you hear the word anaesthesia related to this, something called general anaesthesia. And that is completely understandable. It's what I would think of as well when I think of anaesthesia. And the reason for that is it's completely true. A lot of what we do as anaesthetists is look after patients for surgery. And a lot of the way that we look after patients for surgery is using something called general anaesthesia. And we'll talk about that in a second because it's really interesting, and that is the most interesting bit of anaesthetics, I think. But it is worth mentioning that not every patient that we look after who's having surgery has a general anaesthetic. There are other ways that we can do surgery and keep patients comfortable and pain-free during operations without doing a general anaesthesia. So for smaller areas of the body, for smaller surgeries, say you're having a tooth out, for example, or say you're having surgery to a small part of your body, we can use local anaesthetics. So local anaesthetics are chemicals which the surgeon can inject themselves around the area that they're going to be doing surgery, and that numbs the area and takes away any pain sensations coming from that area. So one really common example that we see a lot in hospital, so I'm going to show you a few pictures of surgeries here, okay, is this called a carpal tunnel surgery. So this is the inside of a patient's wrist. And what's happening here is the surgeons are pulling apart the tissues so that they can release the pressure, because some of the nerves that go to your hand can be trapped underneath tight tissues, and that needs to be released so that we can use our fingers properly again. So the surgeons can inject local anaesthetic themselves just around the area where they need to cut, block the pain signals from that area, and do what they need to do with a completely awake patient who's able to talk to them, move their fingers so they can see how things are working, but with no pain signals coming from that area of the body. So that is great for tiny little areas of the body, small areas, little operations. But for anything bigger, we need an anaesthetist to help administer the anaesthetic. But again, it doesn't need to be a general anaesthetic. Us as anaesthetists can numb whole areas of the body in one go. So if you were having, for example, an operation on your legs, what we could do as anaesthetists is inject local anaesthetic near some of the big nerves in the body, the kind of electrical highways that run up and down the body carrying pain signals. So we could do that by injecting local anaesthetic near the nerves in your legs, or we could do it by injecting local anaesthetic around the nerves in your spine, and that will numb everything from that area downwards so that we can block pain signals. And it doesn't just have to be in the lower limbs or in the bottom of your tummy, it can come in your upper limbs as well. So this patient is having a surgery done on their shoulder, something called an arthroscopy. And this surgeon, who is a chap called Nick Ferren, Mr. Nick Ferren, an orthopedic surgeon, he's doing that operation with this patient completely awake. And he's able to do that because an anaesthetist has done an injection up near the top of your neck, which numbs the nerves down to your shoulder and your arm. And that means that this patient can be awake. They can watch what's happening on the screen where the operation is being looked at. And they can talk to their surgeon, and their surgeon can talk to them. And they can find out what the surgeon can see during the operation. And they can have a discussion together about what to do about what they find in the operation. And this patient can be awake and completely pain-free while they're doing that operation because an anaesthetist has numbed that area. Now, I'm very happy to answer any questions about these things, local anaesthetics and what we call regional anaesthetics afterwards. But otherwise, I'm going to focus mostly on general anaesthesia because it is a bit more interesting, I think. So, what is general anaesthesia? Well, general anaesthetics are not just going to sleep, which was that second biggest word that you used to answer when I asked you questions about what you think of it as an anaesthetic. It's not just going to sleep, but that is part of it. So anaesthetics are often considered to be this thing called a triad, three things happening together, where the first one is unconsciousness or hypnosis, as we sometimes call it. And that is that state of being asleep or going to sleep and being unaware of what is happening around you. So that means patients who are under anaesthetic don't know what's happening around them. They can't hear or see the operation. The next thing is something called analgesia. Now, analgesia is pain relief. Now, you might think if you're unconscious and you don't know what's happening, why do we need to have pain relief? But it's really important that under a general anaesthetic, we block these pain signals as well as just consciousness, because even if the brain doesn't know that the body's experiencing pain, the rest of the body would react to it. Things like your breathing would change and your heart rate would change. So it's important that we block the pain signals with something called analgesia, which is just painkillers, things like morphine. And then lastly, the surgeon needs all of the tissues, the muscles where they're operating, to be relaxed and calm and steady. They don't want them tensed and contracted because it's hard to operate on that. So we use muscle relaxation as well, which relaxes all of the muscles, makes them loose and floppy, and that lets the surgeon operate properly so that they can do their operation well. So general anaesthesia is not just going to sleep, it's three things together: hypnosis, so unconsciousness, analgesia, that's blocked pain signals, and relaxed muscles, which lets the surgeon operate properly. So this is done with a whole collection of drugs, okay? So there's not just one anaesthetic medicine, there's lots of different drugs that we use, a bit of this and a bit of that and a bit of something else to get this balanced picture of these three things happening together. And these drugs, as well as creating hypnosis and analgesia, are really powerful drugs with lots of side effects. And the important side effects that they have are on your heart, and on your lungs, and on your blood vessels. So it makes your heart beat less hard, and sometimes much slower. It makes your blood vessels go all loose and relaxed. and that can drop your blood pressure and can reduce the amount of blood going to your vital organs like your heart and your brain and your kidneys. And they can relax your breathing and very often completely stop your breathing. And so I'm sure you can see, if we were to give these drugs in an uncontrolled way or in the wrong amount or at the wrong time, this could be really, really dangerous. And so because of that, in the UK at least, anaesthetics or general anaesthetics are always given by or under the supervision of an anaesthetist. So what are anaesthetists? Well, anaesthetists are doctors, and we are specially trained in looking after patients before, during, and after operations. It takes at least 9 years of training after finishing medical school to become a consultant anaesthetist. But anaesthetic trainees like myself do lots of anaesthetics ourselves and independently and without direct supervision. But to become a consultant anaesthetist, it takes at least 9 years of specialist training. And during that 9 years, we learn about specialist knowledge. So we learn about physics, and in particular, how gases move and how pressure and volumes interact, that sort of thing. We learn about physiology. So that's how the body works, how the heart works, how the lungs work, how the brain works. And we learn about pharmacology, and that's how drugs work, because we use lots of different drugs ourselves. And also we look after patients taking all kinds of different drugs. So we need to know how those drugs work and how they affect the body. And over those 9 years, we develop specialist skills as well. And in particular, that's skills in what we call managing an airway. So you can see this anaesthetist in the picture is holding a mask onto a patient's mouth, and she's using that to hold their airway open so that that patient can breathe under an anaesthetic. And we learn skills in what's called vascular access. So that's putting drips and lines and tubes and needles, as somebody said, into arteries and veins in the body, including big, important arteries and veins in the body, so that we can give drugs and we can monitor the circulation. So, as I said, anaesthetists mostly work around surgery. And that is the vast majority of what we do, is we work around surgery. And so in order to sort of show you exactly what we do around surgery and how we interact with patients who are having operations, I thought we should follow a case. And we'll follow the case of a patient, a real patient, who I looked after 2 weeks ago when I was making this talk for you guys. And this is our patient. So he is a 79-year-old man with diabetes. He had a heart attack a couple of years ago, and that means that now his heart doesn't beat as strongly as it used to. So sometimes he gets a bit out of breath fairly easily. But because of coronavirus, and I won't mention that coronavirus thing again, we're going to have a break from it for an evening. Because of coronavirus, he hasn't left the house in a year. He's been shielding. And so he's become a bit what we call deconditioned. He's not as fit and as active as he was a couple of years ago. And it's really hard to tell how fit and active he is now, because he doesn't really do anything. He doesn't go anywhere. He doesn't walk to the shops. He doesn't go around the park. So because of that, we don't really know how far he could walk before he gets out of breath. Unfortunately, he's been diagnosed with bowel cancer, and you can see a picture of his bowel cancer on the right here. And this is taken with something called a colonoscopy. So it's a picture of the inside of the lining of his gut, and that big thing sticking out into the middle of the tube is his bowel cancer. Now, he's been discussed at something called an MDT. You might well know about those. They're called multidisciplinary teams. That's where a whole group of clinicians, so doctors and other healthcare professionals, sit down and talk about patients and make plans for how best to look after them. Now, the MDT has suggested something called a curative robot-assisted anterior resection. Now, that is a very fancy way of saying that they're going to use a robot operated by the surgeon. I'll show you that in a bit, because you probably haven't seen a picture of that, and it's quite cool. So they're going to use a robot to remove this last part of his gut. So the bit that's in yellow, they're going to cut that out, and they're going to stick the two ends back together again. Okay. And it's curative because the aim of the surgery is to completely remove and cure this man's cancer. Okay. So you might think that the anaesthetist would meet the patient before surgery on the day, have a chat with them, find out how they are. But actually, the role of the anaesthetist starts much earlier than that. And we actually meet patients having major surgery, particularly if they've got health problems like this chap, sometimes several weeks beforehand. In this case, in an anaesthetic clinic. So in the anaesthetic clinic, the anaesthetist meets the patient to do 3 things, and we'll work through them. So the first thing, number 1, that we need to do in the anaesthetic clinic is we need to work out what the patient's risk is, what his risk factors are that we sometimes say. And we do this by talking to the patient, so we take a history, by examining the patient, so listening to his heart and his lungs, and by doing lots of investigations. And some of these investigations are very basic, straightforward things like some blood tests, perhaps, or doing an ECG, that's an electrical recording of the activity in the heart. But in this particular patient's case, we need to do some more complex investigations to work out his risk. So we're going to put this patient, or we did put this patient, on a special exercise bike, which we have in anaesthetic clinics. So this bike is attached up to this computer screen. We're going to get our patient to sit on it, and we're going to get him to pedal. And as he pedals, it gets harder and harder, like he's pedaling up a steeper and steeper and steeper hill. And while we do that, he's attached up to lots of electrical recordings. We monitor the electricity in his heart, and we measure his blood pressure regularly through the whole thing. And he wears a tight-fitting mask over his mouth and nose that measures all of the gas that goes in and all of the gas that goes out. So we measure how much oxygen he's using and how much carbon dioxide he's producing. And that gives us lots and lots of fancy graphs like this, which anaesthetists are trained to interpret. But basically, we put all of that information that we've got from that test alongside our history and our exam, and it lets us calculate his individual risk scores. Now, down near the bottom of those risk scores is the big scary one, death. So this particular patient's chance of dying as a result of this operation is about 2%. But it's not just dying that we're interested in, and it's not just dying that patients are interested in. There's all of these other things as well. So what's the chance that he'll get a chest infection during or after this operation? What's the chance that he'll have a heart attack during or after the operation? What's the chance that there'll be a complication of surgery, or that the 2 ends of the bowel that they've joined together will break down and come apart? And what's the chance that this chap will be able to go straight home again, or will he need to go to a nursing home or a rehab facility to get better? And we can put all of this information together to produce these sorts of pictures. So this is our patient's picture. And we can sit down with our patient and we can explain all of these risks, and we can discuss what he wants to do, because it is the patient's decision. And for some people, the risk of these things is greater to them than the risk of not having surgery. And that is one option that we can explore, or we can compare that to other treatments. We can consider whether things like radiotherapy would work, or whether chemotherapy is an option. So we can go through all of these different risks with our patient. So that's number 1 thing that we do in an anaesthetic clinic, go through risk and calculate risk. The second thing that we do in an anaesthetic clinic is we work out if there's anything that we can do to help reduce those risks. So for this particular patient, we had a chat with him about nutrition, and we sent him off to see a dietitian to see if we could build up his strength before coming for his operation. We gave him an exercise program, so we can prescribe exercise, because we know that if you're able to build up muscle in particular before major surgery, then you have better outcomes and you have a lower risk. So we sent him off with a bit of an exercise program to see if he could build up some strength before coming for surgery. And we sent him to see a psychologist as well, because we know major surgery doesn't just affect you physically, but it affects you mentally. And we know that if you've seen a psychologist beforehand and you're mentally ready for having major surgery, then you do better in the recovery afterwards, and you're more motivated to work hard in your recovery, because it's not just about the surgeons or the anaesthetists, it's about how the patient works after the operation to see how good a result they have. And there's lots of other things that we talk about to reduce risk as well. So things like, for example, stopping smoking or reducing alcohol, they all make a huge difference. So that's number 2. So number 1, we calculate risk. Number 2, we help patients to reduce their risk if we can. And number 3, we discuss what to expect on the day of surgery. So we talk them through what we're going to do and the different anaesthetic options. So this patient will need a general anaesthetic, but if he was having a knee replacement, for example, we could talk about maybe doing that under what's called a spinal anaesthetic, where we numb him from the waist down, so he doesn't have to have a full general anaesthetic. So we can talk about all those options as well and help prepare him for the day of surgery. So that's the anaesthetic clinic, where we start our input way before the day of surgery. But now we'll jump ahead to the morning of surgery. And you might think it's time to get our patient into the anaesthetic room, time to start doing stuff, put in some drips or some tubes. But no, before I do anything else, first thing I do in the morning when I arrive is my safety checks. Now, for the next 15 minutes or so, I'm going to lean very, very heavily on a kind of pilot metaphor here. And that is partly because I think the only job cooler than being an anaesthetist is being a pilot. But also there are a few other parallels. So when I arrive in the morning, the first thing I do is I check my equipment to make sure I have everything that I need and that everything is working properly. And that's exactly the same as a pilot. Before they take off their plane, they work through their checklist to make sure everything is working and everything is present. And it's exactly the same for me. So I have a checklist that I work through to make sure my anaesthetic machine that you can see in this picture is working properly, that I've got all of the equipment that I need, and that we've got all of the people that we need to do this operation safely. We also check the patient as well, not just to make sure we've got the right person and that we're doing the right operation, although that's important and we do that, but also to make sure that the patient is as optimized, we say, as he could be before surgery. So making sure that he's done those things that we talked about in the clinic, making sure that he's not eaten that morning and that he's not had a drink for a couple of hours beforehand as well, making sure that he's ready to go and that we know everything we need to know about him. Then after I've done my checks, I prepare my drugs. So these are the drugs that I prepared for a fairly straightforward operation. So this isn't our patient's operation. We need much more for a big operation like that. This is a nice straightforward anaesthetic, like you might have if you were coming to have, say, your tonsils removed, or if you needed to have your appendix removed, for example. This is the sort of anaesthetic that I might prepare. And you can see there's lots of drugs, half a dozen drugs for the average anaesthetic there. And they're all labelled and colour-coded, again, as part of safety to make sure that I'm giving the right drug at the right time and that I know what everything is. So there's a few different key drugs there. The ones with the blue labels are our analgesias. They're our pain-relieving drugs. So you can see right in the middle of the picture is morphine, which I'm sure you've heard of, a very strong painkiller. That big white liquid, that's the one that we use to get most patients off to sleep. It's called propofol, and that will send you off to sleep. A syringe that size will send most adults off to sleep for 5 or 6 minutes or so. And then there's those labels, or there's that label in the middle with its red syringe. Now, that one is a muscle relaxant. Anything with a red sticker on it is a muscle relaxant. And that makes all of your muscles relax, and it paralyzes patients because all of their muscles are completely relaxed and they can't move a muscle. And so because of that, it has a big red sticker on it to make sure that I don't give it and that I know what it is and that I don't give it until it is time to, because it is absolutely important that we make sure our patients are completely asleep before we relax all of their muscles and paralyze them. Partly because paralyzing somebody will definitely stop them breathing, but also because one of those things the patients worry about and that we take absolute steps to avoid is that feeling of being awake but not being able to move any muscles. And so we label our drugs very carefully to make sure that doesn't happen and that we use them only at the right time in the right order. So I can see loads of questions coming when I mention that, as they always do. So then our patient arrives in the anaesthetic room and it is time for us to start doing our anaesthetic. But before they go off to sleep, there's a few things that we need to do. Any of you who have had surgery might remember this next bit from coming into the anaesthetic room. There are drips that we need to put in, lines that we need to put in. We need to attach up our monitoring to our patient. And some of this can be done with the patient asleep, but some of it has to be done with them awake before we go off to sleep. And I'll show you a few more pictures here of stuff that we use and that we prepare to get a patient off to sleep for major surgery. So on this big picture on the left of the screen are things called cannulas. So cannulas are little plastic tubes which go into veins, usually in our patient's hands for anaesthetics. And they use a needle to go into the vein, and then we slide the rubber tube in over the needle, and the needle comes out. So it's just a little rubber tube that sits inside the vein. And if we're doing a small operation, something like tonsils or an appendix being removed, we might use one or maybe two of those blue or pink ones, which are the little, very small needle, very small tube ones. But for our patient who's having major surgery and has significant medical problems, we might need 2 or 3 drips so we can give several things at once. And we'll use these grey or orange ones, and they're the big drips. And a big drip is useful compared to a small drip because it means we can give things like fluid or a blood transfusion very, very quickly, whereas things like the blue and the pink ones, fluids can only go through very slowly. So we need to have some good, reliable cannulas into veins before a patient goes to sleep, because that lets us give our drugs, it lets us give fluids, and it lets us give blood transfusions if the patient loses any blood. Just next to them, still on that cardboard tray in the big picture, but on the right-hand side in the middle, are what are called arterial lines. So those are the same sort of things as your cannulas, except rather than going into a vein in the back of your hand, we put them into one of the arteries, usually just about here where you can feel your own pulse. And we put one of those into a patient's artery for 2 reasons, really. One is so we can take blood samples and we can measure the different things that are in the artery's blood. And the other is we can use it to measure the patient's blood pressure, and we can measure their blood pressure constantly through that. So I'm sure loads of you, if not all of you, will have had your blood pressure checked at some time with a cuff that goes on your arm and squeezes. We do that during surgery, but if we're doing a major operation, we need to know a patient's blood pressure constantly, not just every couple of minutes as that cuff can squeeze on your arm. We need to know it constantly so we can react and adapt instantly. And to do that, we need a line into the patient's artery so we can see what their blood pressure is with every single beat of their heart. Because if we're doing major surgery, or if we're doing surgery in somebody with, for example, heart disease, we need to be a lot more accurate and a lot more precise about what we're doing. In the top right picture, that small one where you can see somebody's head and neck, what we're doing there is putting in something called a central line. We usually can do this with patients asleep, but occasionally have to do it with them awake. And this, again, is just like a cannula, except it goes into one of the big, deeper veins in the neck, and it goes all the way down to the entrance to the heart. And it lets us do a few things. It lets us measure the pressure at the inside of the heart. So just like we measure the blood pressure in an artery, we can measure the pressure at the entrance to the heart. And it means we can take samples out of that side as well. So we can see what the different chemicals, the different gas concentrations are at different points in the body. So in the artery and in the central veins, as we say. And it means we can give drugs through these lines directly into the heart that we can't give through small cannulas in the hand. So we need those again for major surgery and for patients who have serious medical problems. And we use those a lot on intensive care as well. And then in the bottom right picture is something called an endotracheal tube. Now, 99% of the time we put these in with patients asleep. But these are tubes that go down a patient's mouth and into their windpipe, or their trachea. And they sit just above where the trachea branches into the 2 lungs. And that lets us deliver gases and oxygen into the patient's lungs. And it lets us eliminate their waste gases, carbon dioxide, out of their lungs. And it lets us measure the pressure inside their lungs as well. And that's because when you're under anaesthetic, you either don't breathe at all or you don't breathe as efficiently. And so we need to take over breathing for patients. And we usually do that with an endotracheal tube. And I'll show you what it looks like when we put those in a second. So once we've got our drips and our tubes and our lines ready to go, or we've put them in, we can get our patient off to sleep. And we do that through this stage, something called induction. So induction is where we go off to sleep. It's a high risk time because this is where we give all of our medicines and our patient moves from being awake to being asleep. And this is where we can see instability in patients. And this is where we as anaesthetists need to be ready. We need to communicate closely amongst the anaesthetic team to make sure we're all on the same page. And this is the time where we have to work really hard to keep our patients stable as they move from being awake to being asleep or under anaesthesia. And this is like the takeoff stage of flying a plane. It's the high risk time at the beginning. Now, once our patient's asleep, we put in that endotracheal tube. And I'm going to try and show you a video of what it looks like when we do that. Obviously, this is Zoom, so sometimes it might be a bit buffery and a bit shaky, and I'm sorry about that. There's no sound, so we don't need to worry about that. And I will pause it every few seconds to tell you what's happening. It's only 10 seconds long or so. So this is something called a videolaryngoscope. It's a piece of equipment that lets us look down a patient's mouth towards their windpipe and towards their voice box or their larynx. So off we go. So we're looking towards the back of the patient's mouth, through their mouth here. This is the back of their mouth. It's all wet and salivary, as you can see. And then you can see this sort of floppy thing hanging down right in the middle of the picture. That's something called the epiglottis. It's a flap which covers our windpipe and stops food going down into our lungs when we swallow. So we put our laryngoscope into that floppy bit, the epiglottis, and we lift it up out of the way. And that exposes what's called the larynx, or our voice box, which is this big black hole in the middle. You can see these two white little strips, one on each side, those curtains, they are our vocal cords. And those are the things that open and close and tense and relax to change the pitch of our voice and makes the sound as we speak. And they also guard the entrance to the trachea, or the windpipe, which is this black hole in the middle. Behind the larynx, you can't really see it, but behind, if you can see my cursor, it's where I'm pointing. Behind all of the larynx is the esophagus, which is the food tube that leads down from our mouth to our stomach. Now, once we get a good view of the larynx like this, the anaesthetist is going to pass down a little blue plastic tube, that's called a bougie, and that sits down inside the trachea through the vocal cords. Got a lovely picture of that there. And then once that bougie, that plastic tube, is in the vocal cords and into the windpipe, he's going to slide his endotracheal tube over the top of it. Here it comes. And that's going to go down and rotate round into the windpipe or the trachea. And once it's in, and you can see it's going in through the cords, he's going to take that blue bougie out. There it goes. And we know now that that tube is inside that patient's windpipe and securing their lungs so that we can breathe for them under anaesthetics. So I'll happily show you that again in a bit, or talk you through what we saw again if you've got any questions on it. But that's one of those procedures called intubations, which we as anaesthetists are trained in, that very few other specialties are. A few other specialties are trained in it. They do it a lot less often than us. So we're considered the experts in intubation, at least in the UK. So then it's time to start our operation. And we take our patient through into the operating theatre. Now, I'll talk you through this picture because lots of you won't have ever seen the inside of an operating theatre before, even if you've had operations. So in this big picture on the left, this is our patient having surgery. So on the left-hand side of the screen, underneath that blue drape is our patient. His head is closest to us and his feet are further away off in the distance underneath that TV screen you can see at the back. In the middle of the big blue drape, you can see his tummy, and the surgeons have inflated it with gas to make lots of space for them to do the operation. And that thing that's grey with all of the light blue lights on it that's leaning over the patient with its arms is the robot. It's called a Da Vinci robot, after Leonardo da Vinci, I assume. And it has 6 arms, which are operated by the 2 surgeons, who you can see kind of in the middle of the picture. They're on that right-hand wall and they're looking down into their robot like that. You can see them in their hats at that back wall on that side. They have some little forceps type things inside where they're looking. And the surgeon sits like this, they look down into their machine like this, and they've got their surgical arms, and they can move the arms, their arms, like this, and they can pinch and open and move things like this. And the robot on the other side of the room's arms move in response. And the reason they do this, rather than just use their own hands, is the robot can be really precise and really accurate. It's got these kind of millimeter tiny movements, so they can do really intricate, detailed, delicate surgery, much more delicate than you can do with human hands, basically by zooming everything in and making a movement this big on your hand a movement that is tiny in the robot's hand. So they're able to do this really delicate surgery through keyholes in the patient, meaning that they can have their detailed, kind of intricate operation without having to completely open the patient's tummy. And that means they have a much better recovery, and they have less pain afterwards, and they have less complications of surgery. And that's the idea anyway. And everybody else you can see in the picture is either what's called a scrub nurse, who is there providing all the different pieces of equipment and making sure the surgery runs the way it's meant to and is sterile and is running properly, or an assisting doctor, so the person who's sat closest to the patient is another doctor who's also operating one of the robot's arms and helping to change the robot's pieces of equipment. And on the TV screen, we can all see what the surgeons can see as well, so that lets us know what's happening in the operation. And I'll answer any questions that you've got about the robot stuff, because I know it is quite cool. But we're here to talk about the anaesthetic. So closest to our picture, this big white machine nearest us, this is the anaesthetic machine. Now, this stage of the operation, if we're going back to my flying a plane metaphor, is like the maintenance. It's when we're cruising at 36,000 feet, and a pilot might put their plane on autopilot, and I might put my patient onto a ventilator. So this machine, this anaesthetic machine, has a ventilator built into it. What that means is it can take over the work of breathing for my patient. So I can plug them into the ventilator, and it will deliver gas into the patient, and it will allow the waste gases to come out of our patient as well. And I can program all of the different settings in the ventilator, which is why my knowledge of physics is useful. And in this bottom right picture is my physics screen on the anaesthetic machine. It shows me the gases that are going in, the gases that are coming out. It shows me the pressures and the volumes, and I can look at graphs and waveforms and all this fancy stuff, which tells me exactly what's happening with my patient's lungs and ventilation as the machine breathes for them. In the top right picture is my physiological monitor, and this is where I can monitor all the different organ systems to tell me what's going on in my patient's body. So the green line is an ECG, that's a recording of the electrical activity in their heart. The yellow line tells me how much oxygen is in their blood. It shows me the saturation of oxygen in the blood. The red bouncy line is their blood pressure with every beat of their heart. That's the recording that's coming from that arterial line in their wrist. It shows me what the blood pressure is with every single beat of their heart, so I can monitor it closely. And that blue slow waving line, that is the pressure within the right side of their heart in one of those big central veins. So the red line lets me measure their arterial pressure, and the blue line lets me measure their venous pressure. So I can measure the arteries, I can measure the veins, the electrical activity, the oxygen levels, everything. So if you're the kind of person who likes attention to detail and controlling things, then anaesthetics might definitely be the thing for you. We have absolute control over every aspect of our patient's body while they're under anaesthetic. And we can control everything, which is why I like anaesthetics. You can be a control freak. Now, mostly it is like cruising a plane. We can put it on autopilot and we can sit back and everything just sort of happens while the surgeon does their thing, and then we can wake them up at the end. But if the surgery is a bit more challenging, if there's bleeding, if the patient has any medical problems which happen during surgery, then it can be a bit more complicated. And then rather than just sitting back on autopilot, it's a bit more like trying to fly a plane while one of the engines is braking, or even worse, while a surgeon is braking the engine as you're trying to fly the plane. So we have to be ready for anything. We have to be able to adapt. We have to be able to fix any problems that might happen during surgery. Then at the end, we land the plane. This is the other high risk time as we wake our patient up from the anaesthetic. As the anaesthetic wears off and they transition from being asleep to being awake, this is the other time that we have to be ready to react to problems that might happen and talk closely amongst the team. Now, this is where anaesthesia ends for most patients. They wake up and they go home, or they go to the ward to recover, and we'll see them afterwards and see how they're feeling, make sure they're comfortable and they're not feeling sickly. But for most anaesthetists, this is the end of the story. But for some anaesthetists, they choose to specialise in intensive care. And anaesthetists who specialise in intensive care look after critically ill patients. Now, a lot of those critically ill patients have had major surgery. And so anaesthetists are part of that intensive care unit team who look after patients after major surgery and help with their recovery. And to be honest, this is where really the things that affect whether a patient has a good outcome or a less good outcome after surgery happens. It's all in this recovery stage afterwards. But as well as critically ill patients who've had surgery, there are patients who've had things like traumas, so car crashes, gunshots, all that sort of thing, who are looked after in critical care. And of course, there's that thing that's been going around, coronavirus. So that, as well as other medical problems, are also looked after in critical care by a team of doctors who are trained in intensive care, but whom anaesthetists make up the vast majority. Okay. So some anaesthetists choose to specialise in intensive care, and I thought I'd finish by telling you some of the other things that anaesthetists can choose to specialise in as well. Because not all of us choose to specialise in intensive care. Some of us choose to specialise in certain types of surgery. So in this big picture on the right of the screen is the setup for a cardiac anaesthetic. So some anaesthetists choose to specialise in cardiac surgery or cardiothoracic surgery, and this is what it looks like on the anaesthetic side during open heart surgery, for example. So you can see up the middle of that big picture, there's this whole stack of pumps, and each of those has got a different medicine in it that's being used either to keep the patient asleep and comfortable or to keep their heart beating properly during cardiac surgery. At the very bottom right, just next to the anaesthetist red chair, is a machine that's measuring the oxygen levels inside the patient's brain. And that's partly because it helps us to know how asleep and how awake the patient is, but also because it tells us how efficiently their heart is managing to function during surgery to make sure enough oxygen is getting to the patient's brain during heart surgery. And in the bottom left of that big picture is something called an echo probe. And that's a probe that a cardiac anaesthetist can use to put down the patient's mouth into their esophagus to be able to look at what the heart is doing during or after or before, so before, during and after heart surgery, so that we can measure exactly how well the heart is beating during surgery and after it recovers. There's also a machine just to the right of those pumps, at the back of the anaesthetic machine, called a defibrillator. The anaesthetist uses that to deliver electricity directly to the heart if it goes into a strange rhythm or even stops beating during heart surgery. So other anaesthetists don't choose cardiac anaesthetics, they might choose paediatric anaesthetics. And here we look after children having surgery. And this goes right from 16, 17-year-olds who are very close to essentially being adults in terms of how we look after them, right down to premature babies who might be born months before they should have been. And these babies have special medical problems or unique medical problems, which need a good understanding of how a very young baby's physiology is different from an adult. So these are paediatric anaesthetists. And down in the bottom left is a picture of some neurosurgery, brain surgery. So some anaesthetists choose to specialise in neuroanaesthesia. And neuroanaesthetists are specialists in looking after the brain and the spinal cord during brain and spinal surgery. And here in this picture, a neuroanaesthetist has anaesthetised a patient's skull and a patient's scalp so that this patient can have brain surgery. So they've opened the skull and the scalp and they're doing brain surgery with this patient awake. That patient is able to talk to us. They're able to move their arms and legs. And in this picture, they're able to play a violin. And that is useful because it means that in this case, a surgeon can remove a tumour from the patient's brain whilst making sure they're not removing any good brain tissue, because unfortunately brain tumour and actual brain tissue can look very, very similar. But by having our patient awake, we're able to make sure that we're not using an important, or we're not touching an important part of the brain during surgery. And you need a neuroanaesthetist to make sure that you can do that with a patient awake and comfortable. Some anaesthetists specialise in obstetrics, making women who are in labour pain-free during childbirth. and even able to have what are called cesarean sections, where we are able to deliver babies through the tummy using a cut whilst completely awake and completely pain-free. We do that by an injection near the spinal cord, which numbs patients from the top of their waist all the way down, so they can't feel anything painful during childbirth. And some anaesthetists specialise in chronic pain. So they use a combination of talking therapies and cognitive behavioural therapies and psychological therapies to help manage patients with long-term pain, whilst also doing procedures like in this picture, where an anaesthetist is doing an injection close to a major nerve central in the body under close X-ray guidance, that's what that big C arm is, to help treat strange and unusual pain syndromes, things like phantom limb pain that you might have heard about, where patients can have pain in a limb even after it's been removed. And having our unique set of skills and our unique set of knowledge means that we are really useful for pre-hospital care as well. So we're one of two specialties which can subspecialise in pre-hospital care, where we can deliver life-saving critical care outside of the hospital. That means that we can go on air ambulances and treat patients at the scene of accidents, car crashes, cardiac arrests. It means that we are very useful in the military setting as well. So if any of you are in cadets, for example, we are very useful in the military setting, again, to help treat traumas like gunshots and explosions. And we are very useful in sporting events as well. So in this bottom left picture, Romain Grosjean is being pulled from his Formula One car in the first lap of a race after it exploded and hit the barrier and exploded. And that man right there, close to the centre of the fire, pulling Romain Grosjean out of the fire, is an anaesthetist. So we are very useful in a variety of settings because of our skills. So I've gone a little bit longer than I wanted to talk to you about there. So I'm sorry about that. So that's been about 50 to 55 minutes nearly. But I have got time to answer questions if you've got any. I hope that's a useful overview of what anaesthetists do, and that it's not just sleep. There's a little bit more to it than that. And that we do have this kind of unique set of skills that hopefully means we are useful both in and out of the hospital.